the things which we usually do not normal pulse, BP and respiratory system, and the what we so common called the pickle, that is the pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema. The other markers which we very commonly miss in our general examination, like the cutaneous markers of atherosclerosis, peripheral signs of AR, signs of Marfan, signs of endocarditis, signs of acute rheumatic fever, fundus, and external markers of congenital heart disease. I think these are the things in which all the cases of general examination, even as a negative point, we should tell in examination, like there are no features of this, there are no features of this. In all the cases, we should make it a habit, telling, even at least in a congenital heart disease, we should tell there are no external markers of congenital heart disease. In the case of other cases, we should tell no features of endocarditis, no features of rheumatic fever, and so on. So I think these are the points which we'll cover in the next 1 hour. So first of all, I'll try to cover, this is my most important and the thing which I like the most, the cutaneous markers of atherosclerosis. This is one thing which we discuss the least. This is very important. There are many markers of atherosclerosis from head to toe which we need to discuss. I'll come one by one. Now, the first important point is xanthelismas and the xanthomas. Now, why are this important? Is in a patient with many a time we encounter patients with premature coronary artery disease, and they have a family history. You see these lesions. I just put the pointer. Pointer on. Yeah, you see these lesions. These are known as the xanthelisma. They are more commonly present on the upper lid, more commonly symmetrical, and then the lower lid. And then you see these are known as the xanthomas. They are sometimes the eruptive xanthomas on the knee, then the tendinous xanthomas, again eruptive xanthomas, again on the Achilles tendon, the tendinous xanthomas and the palmar xanthomas. Now, why are these important? In many cases of familial heterozygous and homozygous hyperlipoproteinemia and cholesterolemia, you get these things. You have to call you see the patient, you tell the patient, relatives, tell the brother, sister to come and then see in them also. Most commonly, you will see in them also these markers like the xanthomas and the xanthelismas. And then when you do LDL in this, you'll see the very high levels of LDL 500, 600. Why this is important? Because one thing is, they tend to have premature atherosclerosis, and the family history is very important. And second important thing is, before and all, we used to do a lot of therapies like apheresis, plasmapheresis and all. Nowadays, we have one important drug known as PCSK9 inhibitors, which have come as a class 1 drugs for the treatment of homozygous and heterozygous familial hypercholesterolemia. So this is one of the important markers, like the xanthomas. Let it be eruptive, let it be tendinous, let it be palmar. Now, one of the most important questions which they ask in exam is which type of xanthomas are seen in which hyperlipoproteinemia. I usually remember it as ATP or ETP, you can remind. So type 1 has eruptive, type 2 has tendinous, and type 3 has palmar. Though there may be some overlap, but this is the common, E, T and P. And type 2 hyperlipoproteinemia is usually associated with venous in aortic stenosis. So early onset aortic stenosis usually is associated with type 2 hyperlipoproteinemia. Now, as we go into more detail, there is something known as arcus juvenilis. Now, again in the patient with hypercholesterolemia or patient with the alcohol, blood pressure, cigarette smoking, diabetes, and so on, something known as cornus. In the cornea, this deposition of the lipid, and this is as more is this arcus, the more severe is the atherosclerosis. So this arcus juvenilis is again an indicator of high cholesterol or a marker of coronary artery disease sometime. Now, as you go more in a patient with xanthomas or xanthelismas in the fundus, you may see something known as lipemia retinalis. I will come to that, but in the retinal examination, fundus examination, it is known as, you see chalky white fundus, that is the lipemia retinalis. So these three things are very important in the case of atherosclerosis or a marker of atherosclerosis. Now, this is again one important feature is acanthosis nigricans, a marker of metabolic syndrome. Not only a marker of metabolic syndrome. Now, what are acanthosis nigricans are? These are darkening or the hyperpigment. This is most of you would have seen a hyperpigmentation or a darkening. It is a hyperkeratosis seen most commonly at the nape of the neck. It can be seen in the axilla or it can be seen in the groin. Most commonly, we encounter this in the patient with metabolic syndrome. I think all of you should know the definition of metabolic syndrome. I am not going to discuss metabolic syndrome now, but that you not only in metabolic syndrome, acanthosis nigricans is also seen in obesity. It is a marker of internal malignancy. It is also seen in the drug-induced hereditary malignancy, polycystic ovary syndrome, again as a part of metabolic syndrome, and also in Cushing syndrome. So acanthosis nigricans can have many differential diagnoses, but as a part of cardiovascular disease, you should know it is a marker of metabolic syndrome. Now, coming to the next marker are the skin tags. Now, skin tags, usually we know they are a benign thing, but sometimes the skin tags can reflect insulin resistance states, or again a feature of metabolic syndrome, or they can be associated with atherosclerosis. So they are usually benign, but they can sometimes be associated with atherosclerosis. And this is one important thing which we have studied in a lot of small studies. Two important things. One is premature graying of hair. So premature graying of hair and a androgenic alopecia, male pattern baldness. These two things were studied with the increased incidence of coronary artery disease. So I think we should always remember a premature graying of hair and a male pattern baldness, that is the androgenic alopecia, are associated with early onset coronary artery disease. Now, this is one thing which is, I think, some of us know, some of us don't know, but I think we all should know. All of our patients, in a patient with coronary artery disease who undergone stenting, go bedside, see their ear, see this diagonal earlobe crease. This is known as the Frank sign. From the tragus, you see a 45-degree diagonal line. From the tragus, please, I again request, please do not annotate, do not take the marker of ear into the slides. So this is a diagonal earlobe crease. It is a 45-degree backwards from the tragus to the auricle. It is a line, and it is known as Frank sign or a earlobe sign. So in most of the observational study, it is found that there are high prevalence of this in a patient with atherosclerosis in even less than 60 years of age. When they found out that, they found a large prevalence of this sign. So I think this is one of the important sign phenotype. I think we should look in most of our patients this thing. So it is known as a Frank sign. Now next few things are what is known as the secondary markers. So this nicotine staining. So this may be associated with what is like a patient with having chronic heavy smoking and all. So you should always see in those patients nicotine staining in the hands. Now there is other thing known as the beetle quid cellar syndrome. So this is what they have characterized by central obesity and brick brown lips and palms. So this is usually found in patients with in Asian countries, mainly in the Indian, Pakistan, Bangladesh, Nepal belt, where they have a full teeth is because they take a lot of betel quid, and it is usually associated with diabetes, hypertension, and CAD. Now, again, important thing as a part of metabolic syndrome, central obesity. We should look in all of that's what Dr. Tom told me, central obesity or obesity. So waist hip ratio is an important marker. So I think before, what was definition of 190 centimeter is changed now to 90 centimeter in South Asians and 80 centimeter in females. So 90 centimeter in males and 80 centimeter in females. So this has changed and come into the metabolic syndrome definition in South Asian population. So central abdominal obesity has become a very important thing. Now, apart from that, we should look in all the patients the markers of peripheral vascular disease, because whenever we do a patient, apart from coronary artery, like a carotid artery, we look for carotid artery disease. We always look in those patients for coronary artery disease, renal artery disease, and peripheral disease. In a patient with peripheral disease, we always look for coronary artery disease and carotid disease. Why? Because there is a high prevalence of coronary artery disease in a patient with peripheral or carotid artery disease. That is why in all those patients we should look for a peripheral signs, and we know there are 5 P's, that is the pulselessness, paralysis, paresthesia, pallor, and pain. So we should always look for this signs in a patients with coronary artery disease. Next important sign is signs of gouty arthritis, what is known as tophi. There are so many studies which are done and showed that gout is associated with coronary artery, not only coronary artery disease, even in patients with heart failure, gout, uric acid, and HSCRP, and those are very high. So gouty arthritis and markers should be looked for in a patient with coronary artery disease. Now, there are few rheumatological diseases which have been associated recently, last few years, with coronary artery disease. One of them being a rheumatoid arthritis. So in all patients who have female population, younger female population who comes with you, I think we should look for ask for a history associated with rheumatoid arthritis. Mainly, if they have a history of they are on HCQs and there is a history of SLE and all, we should always rule out associated rheumatoid arthritis and look for the peripheral markers of rheumatoid arthritis in those population. These are all the general examination findings. I think from our medicine days, we know all these findings. I won't go into the detail. And finally, psoriasis. This is again one disease which has been coming. There is a role in acute coronary episodes. The psoriasis increases the chance of acute coronary episodes. Now, there is one more thing which many examiner ask in a patient who has psoriasis. So we have the beta blockers may precipitate the psoriasis lesions. So we usually avoid beta blocker because they increase the lesions of psoriasis and they precipitate it. So always avoid beta blockers in a patient who has a psoriatic lesions. So this is one important point I think you should take home. Now this were the markers of coronary or atherosclerosis. Now let's come to the peripheral signs of aortic regurgitation. Now this is one of the important slide. Now I have a request. What is on my left hand side? Again, a request, Rahul, please.
Dr. Rao, just what I would request once, if you can unshare and reshare the screen, because as you know, Shantanu sir is not there, so he's having that control of removing annotations. I'm calling him.
Sorry, I do.
You can just unshare and share. That's
it. Share, yeah. Okay.
And our participants, yes, it's fine, perfect. All the participants, please do not move on the screen. It will keep the annotations and marks.
Okay, fine. So I will continue. Now let's go to the peripheral signs of aortic regurgitation. Now, what is on my left-hand side? People who are in MBBS, who are in MD, they can try to mug up few of the names. There are 20 signs or around 18 to 20 signs of aortic regurgitation. They can mug up the names. As you come to the DM and you come to the practice, it is literally not possible to know the names. Try not to know the names and go into the more logical reasoning, because from head to toe, there are literally 20 signs. I will try to discuss what is the important signs. So the most important signs, I think in the back to basics, we have discussed and we have even demonstrated a water hammer pulse. So this is the most important thing, is a collapsing or a water hammer pulse. Now, what is the mechanism of water hammer pulse? We have already discussed. A water hammer pulse is due to two mechanisms. There is a central mechanism and there is a peripheral mechanism. The peripheral mechanism, we all know. What happens is, as the hand is raised suddenly up, the outer, because it is directly in line with it comes in the line with the blood goes off into the LV, and then there is suddenly runoff. So that is the peripheral mechanism. Now, what is the central mechanism? Is because all the blood is run off into the LV ejects. The blood ejects from the LV. It causes the activation of the baroreceptor. Now, when the baroreceptor is activated, it causes a decrease in SVR. So when the SVR decreases, it again causes peripheral runoff. So this is the central mechanism. So aortic regurgitation, the collapsing pulse has both the central mechanism and the peripheral mechanism, and the peripheral mechanism plays over the central mechanism plays over the peripheral mechanism. Now, again, there are many important signs. One of the most important sign which was discussed a lot over past and present is Hill sign. Now, what is Hill sign is, all of us do till now Hill sign. So a difference between the lower limb. Mind you, Hill sign, what is actually mentioned is the lower limb popliteal BP, a lower limb popliteal BP and the upper limb brachial BP. The difference between the popliteal and the brachial BP more than 20 mmHg. So if it is more than 20 mmHg, Hill sign is positive. 20 to 40 is mild, 40 to 60 is moderate, and more than 60 is severe Hill sign. So BP in the lower limb is more than BP in the upper limb. Now, two important take-home messages. First, Hill sign is a sphygmometric artifact. Means when you do a invasive BP monitoring in the lower limb, the BP, invasive BP, systolic BP is same as the invasive BP in the upper limb. So Hill sign is nothing but a sphygmomanometric artifact. But at the current era, 2020, Hill sign is still important. So do not discard what I told on the fact that Hill sign is not important. However, there is one important sign which has very high sensitivity. So out of all the peripheral signs of AR, the sign which has the highest sensitivity is Durozius sign. So what is Durozius sign is, all of you will know. So when you're in the femoral artery, if you do a distal compression, you get a diastolic murmur proximal to the compression. So D. Diastolic murmur in the distal compression is the Durozius sign. Now, why is it diastolic murmur? Because you're compressing it distally. So there is a runoff in the proximal part. So that is why you're getting a diastolic murmur. And out of all peripheral sign, Durozius sign has the maximum sensitivity. There is a sensitivity of 90% and specificity of 100%. However, Hill's sign has a sensitivity of only 69%. I am getting many questions. I am not able to see that. I will try to answer all of this in the end. Maybe, yeah, I'll try to answer all of this in the end. So Hill's sign has a sensitivity of 69%. Now let's go head to toe other important sign. So when you see there is something known as lighthouse sign. There are blanching and flushing of the forehead. After that, you see there is a visible pulsation of the retinal and arterioles when you do a fundoscopic examination. Then there is a Muller signs, visible pulsation of the uvula. Now, one important sign is de-Muset sign. This is one important thing. One of the old-timer teacher always tells me, head nodding with each heartbeat. There is yes sign in aortic regurgitation. That is called a de-Muset sign. Head nodding with each heartbeat. However, tricuspid regurgitation causes a no sign because there is no sign. So there is something like a no sign in tricuspid regurgitation, whereas the head nodding with each heartbeat in aortic regurgitation is known as the yes sign. So that is the de-Muset sign. The other important peripheral sign means peripheral feature. What you see in tricuspid regurgitation is proptosis, which you all know. Then there is something known as Quincke's sign, which is not very difficult to demonstrate. Some people take a slide and put over the finger and they demonstrate them. Two important signs apart from Durozius is Trobbe's sign. That is a pistol shot sound. You put a stent over the femoral, you get a tuck, 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 pistol shot sounds. Then two important signs, one over the liver, what is known as Rosenbach sign, and one over the spleen, it is known as Gerhardt's sign. So these are all the peripheral signs of aortic regurgitation. Now, I want to tell you one thing important. Remember the importance and limitation of Hill sign. Remember, Durozius sign is the most important peripheral sign, and not all the patients with severe aortic regurgitation you will get a Hill sign, and not all the patients whom you get a Hill sign may have a severe aortic regurgitation, because there are other causes of Hill sign also which are there. So this is one important thing which I wanted to tell you about aortic regurgitation. Yeah. So I'll go to the next slide. This slide is not. Yeah. Now let's come to one important thing. Now this is something which is very important, that is signs of Marfan syndrome. I won't call it Marfan syndrome now. I will call it signs of Marfanoid habitus, because when I tell Marfan syndrome, it becomes a syndrome. You mean I have diagnosed it by something known as Gent's criteria or modified Gent's criteria. People who are in MD or people who have done in DM, they know there is something known as Gent's criteria. There was Gent's criteria, now they have change it to modified. So you diagnose it by G score, something known as Z score. There are many points, and based on G scores, major points, minor points, you diagnose. Now, Marfan syndrome, there are many phenotypic features. Now, from head to toe, there are many. Now, let's come to one by one. One of the most important thing which you have to see in an eye is dislocation of the lens. Some patients do tell you there is a history of eye surgery in the childhood. We also have encountered many patients. Now, what type of dislocation does Marfan cause? It causes supromedial subluxation of the lens. And how it is different from homocystinuria, that cause a infratemporal subluxation of the lens. So a Marfan's has supromedial, whereas homocystinuria has infratemporal subluxation of the lens. When I was an MD, one of the examiner in my MD examination asked me, what are the other features do you know to differentiate it from homocystinuria? Marfans usually have a high IQ as compared with homocystinuria, which usually presents with mental retardation. So this is usually one more important feature in differentiating Marfans from homocystinuria. Now, second important point is high arched palate. All patients with Marfan look for high palate. So what you have to do is, the clinician asks the patient to stand straight, look forward and open the mouth. Normally the posterior, what you have to look is the posterior part of the palate. It is usually easily visualized. In patient with high arch palate, the hard palate, that is the uvula, is not visualized. I will come to the picture. So yeah, sorry, yeah. So see, you can see this. There are the first picture. There is a normal. You see a mild degree of high arch. This is a moderate high arch, and you see there is severe degree of high arch palate. So apart from Marfan syndrome, there are many other causes of high arch palate like Turner syndrome, Noonan syndrome, Friedreich's ataxia, and whatnot. So I think we should just remember one or two important causes of high arch palate. Now let's go to few other signs. So this is known as the thumb sign. I think this you have to all the patient who comes with aortic regurgitation, or any patient who comes whom you are doing a rheumatic case, you have to look for Marfanoid thing. So tell them to do a thumb sign. Thumb do like this. So normally when you make a fist or a clenched thumb, it does not extend beyond the ulnar sign of the hand, but you can see in the picture the thumb sign is positive. It does happen in case of a Marfan syndrome. And now what is this is wrist sign. So in wrist sign, what we do is thumb and the little finger. Normally there is no overlap. However, if the overlap happens, if there is an overlap of this, then you say the wrist sign is positive. Now, apart from this, there is something known as the metacarpal index. Now, what is the metacarpal index? This is actually a radiological sign. I think we should little bit know about this. So the average length of the second, third, fourth, and fifth metacarpal bone divided by average breadth of the second, third, fourth, and fifth bone. So at the mid palmar level, normally it is 5.4 to 7.9. In Marfan's, it becomes more than 8.4. It becomes 8.4 to 10.4. So if the ratio goes beyond 8.4, it is suggestive of Marfan's. So this is known as the metacarpal. Now, two important things. All the patients we know in a general examination, we have to do two important things: upper segment, lower segment, and arm span and total body height. Now, why is it important? Is normally the arm span and total body height, the arm span is never more than the total length. If the ratio of the arm span to the height is more than 1.05, it is suggestive of Marfanoid body habitus. Remember this, arm span divided by total body height. If the ratio is more than 1.05, it is suggestive of Marfanoid. Second thing, normally the upper segment and lower segment are normally the upper segment is more than the lower segment. So if the lower segment is more than the upper segment, if the lower segment is more than the upper segment, or if the ratio of upper to lower is less than 0.86, this ratio again, remember, if the ratio is less than 0.86, it is again suggestive of Marfan's. So these two important point you should always remember: arm span to total height and upper segment to lower segment ratio. So lower segment more than upper segment, again you get in three diseases apart from Marfan's, in Klinefelter's and homocystinuria. And apart from, where do you get lower segment equal to upper segment? Always remember, in acromegaly you can get a lower segment and upper segment equal. Apart from the constitutional, you can get in acromegaly. And acromegaly, you know, is associated with other cardiovascular manifestation like hypertension or cardiomegaly. It can be associated. Okay, now let's move to the, so in the table you can see the other signs. So apart from this, you know, there are other manifestations like long slender fingers. Now they are most commonly spine deformities, scoliosis, and you can get kyphosis also. Then pectus excavatum. So if the sternum caves into the chest, it is known as excavatum, and if it is a protrusion, it is known as carinatum. Then you can get arachnodactyly, like there are long slender fingers and all. So those things you can get. Then you can get, apart from that, pneumothorax and all in the lungs. And then most important thing, cardiovascular manifestation. So if somebody asks you what cardiac findings you get in Marfan's, you have to know you can get aortic regurgitation. Why? Due to aortic root dilatation first. Second, you can get due to aortic dissection. Second, you can get mitral regurgitation due to mitral valve prolapse. You can get tricuspid valve prolapse also. So these three things are important. You should remember. Apart from that, you can get various hernias and all also, inguinal hernias and all. So these are the points in Marfan which you should all remember. And all patients, you should look for the signs of Marfan, let AR be there or not there. All rheumatic heart disease look for Marfanoid hepatitis. Take my words. Now, this one important thing is science of to endocarditis. Now we just go in all general examination, we just close our eyes and tell there are no signs of infective endocarditis. And somebody asks what are the signs of infective endocarditis? You tell there is no splinter hemorrhage, there is no auscultating node, there is no Janeway lesion. Remember, they are not asking you this. Start from the first. What is the most common sign you get in infective endocarditis? Is fever. The most common sign is a fever. Always tell there is no fever or there is fever. There is pallor or not. Pallor is again an important peripheral sign in infective endocarditis. There is clubbing or not. So clubbing, it takes 4 to 6 weeks to develop in infective endocarditis. So there is clubbing or no clubbing. Then there is splenomegaly or no splenomegaly. You can get cafe or late pigmentation. So some light pigmentation. Then you can get arthritis and cachexia. Then come to the real peripheral signs. Now, what are the peripheral signs? You can get petechia. You know the small petechias you can get in conjunctiva or buccal mucosa, which can either be vasculitis or emboli. But the 4 important peripheral signs of infective endocarditis are splinter hemorrhages, auscultating node, Janeway lesion, and Roth spots. These 4 you should never forget. So what are splinter hemorrhages? Splinter or subungual hemorrhages. Look in the nail bed. You get in around 15% of the cases, there are linear red-brown streaks, and they usually can be vasculitic or embolic. They can be both. So splinter or subungual hemorrhages. Now next are auscultating nodes. Auscultating nodes are painful. Always remember. And where do you get? You get in the fingers and toes. You have to see at the 2 points in the fingers and the toes. They are painful and they are 2 to 5 mm and they are vasculitis. Vasculitis, when I mean, it means they are associated with RA factors, means they are rheumatologic, they are immunologic. And what are Janeway lesions? They are painless and they are usually found on the palms and the sole. And you have to look carefully in all endocarditis under surface of the foot. So I have missed many cases the Janeway lesion because we have not examined the cases under surface of the foot. So you can get painless lesion on the palms and the soles, Janeway lesions. They are usually embolic and not the immunologic. And Roth spots, all case of endocarditis or otherwise also look fundus. Why? You may miss something known as Roth spots, which is a pale retinal lesions, and it is usually surrounded by a hemorrhage. They are usually due to vasculitis. Again, immunologic phenomena. Now you can see the Roth spot. There is a center, there is a ischemic point, and it is surrounded by. You can see the hemorrhagic point. Now these are auscultating. As already told, in the fingers and the pads of the foot, you can get auscultating nodes. They are painful. Janeway lesion in the palm and the sole. These are the subungual and the subsplinter hemorrhages. I am not discussing much on the other findings of the fingers, but you should always look in all the patients with all patients pallor, like your type of anemia, because flat nails you can get. So they can suggest, and then you can get something suggestive of Raynaud's phenomena, dystrophic nails and all. You can get half and half nails. Half and half nails we usually get in malnutrition. You can get in hypoalbuminemia. Even post-Fontan surgery, some patients get a half and half nail. That is called as Lindsay nail or Terry nails. So all those cases you should always see the nails. So nail finding is an important finding in also a cardiovascular examination. I just wanted to highlight few important findings. Now next is signs of acute rheumatic fever. Now why this slide is important is in all the case of rheumatic heart disease, when the patients present with rheumatic heart disease, do not means a patient who is 40 or 50 plus, do not assume that they cannot have rheumatic fever. There are most of the patients usually do not have rheumatic fever beyond 40 or 50, but always in all patients with rheumatic heart disease, rule out an associated or an acute episode of rheumatic fever, let it by a ASO titers or other things like a CRP, ESR. You should rule out because there are many causes. Some patients may not have a previous LV dysfunction and now present with LV dysfunction. So a new onset of LV dysfunction can sometimes be because of acute carditis and all. So there are some subtle findings which tell that the patient has acute rheumatic fever on a background of acute established rheumatic heart disease. So we should not rule out just because the patient is old that it cannot have acute rheumatic fever. So always ask for history. And second, see for a signs like fever and then arthritis. No, I'm not going into the detail because rheumatic fever is a book in itself. You cannot discuss it in a 1 hour. So usually it is a typical polymigratory arthritis. The latest criteria of rheumatic fever, all of you should know. It is no longer what we used to discuss. It has changed in a high endemic area, low endemic area, major, minor. It is all different. But what was a typical dictum is arthritis is inversely proportional to carditis. Chorea is directly proportional to carditis. Most of that still holds true. So all the patients, you still look for features of arthritis. Is there a swelling in any limbs? Now, next important feature is Sydenham's chorea. Now, I'm not going into detail, but there are signs of what is chorea is. You have to look for involuntary movement, quasi-purposive involuntary movements, or they are usually associated with neurological manifestation or emotional lability. And also they have so many peripheral signs like milkmaid sign. They can have a hand extension abnormalities, they have a tongue abnormalities, they have hypotonia, they have hung up reflexes. So many Sydenham's chorea, and it can occur as early as 6 weeks and it can occur as late as 6 months. So do not assume that the Sydenham's chorea is an acute manifestation. It can come anytime from 6 weeks to 6 months. So chorea is but sometimes if a chorea is there, most of the people you have it there, that carditis has to be there. So that is one important thing. So chorea is one thing where you have to look for many important peripheral signs. Now erythema marginatum. Now I'll show this with the help of a figure. Now you can see erythema marginatum is these are usually transient features. Macular, it is non-pruritic. Most important thing is it is a non-pruritic rash. It is serpiginous with a border. Most important 5 centimeter, usually in the proximal limbs and trunks, and it blanches on pressure. So there are many differential, like you can get in sepsis, drug-induced acute glomerulonephritis, and idiopathic. So these are some of the important differentials of erythema marginatum. So, and the last important thing is subcutaneous nodules. So these are small, painless, usually seen on the extensor surface or the bones or tendons, but they can occur anywhere. But most commonly on the extensor surface or the bones and tendons. So all patients with established rheumatic heart disease look for the signs of acute rheumatic fever. Yeah. Now one of the most important finding is fundus. I think after a student, DM student or a cardiologist after his MD examination, I think we stop touching the fundoscope. I think we should hold sometimes and look for some of the features, at least in important cases. So I won't go into detail, but which all diseases, what all to see, I just go into the brief. So in all the cases of diabetes, what do we see in diabetes is, we see the most earliest feature is edema. In diabetes, the first sign to come is edema. Then you get something known as dot blot hemorrhages. You get known as soft exudates, hard exudate. Cotton wool spots are one important finding, and then microaneurysms, and finally neovascularization, and it can end in glaucoma, neovascularization, proliferative glaucoma and all. So diabetes is one of the important thing which we have to look for, because the cardiovascular diseases or coronary artery disease is important. Hypertension. Now again, one of our important territory is hypertension. The important classification is Kith and Wegener classification. We may not remember this classification, but there are few important points which you should know is AV nicking. This is one keyword. AV nicking is important. Arteriolar and venous reflexes. These are one important thing. Hard exudates can be there. Cotton wool spots can be there. Finally, you can have copper rings and silver rings. Copper wiring can come early, silver rings can come later, and finally patient may end up in papilloedema. So at the end of the day, we should know how to look for papilloedema in our cases. Now, next finding is, as I already discussed, chalky white fundus, which we usually see in lipemia retinalis, where due to lipoprotein lipase deficiency, elevated triglyceride can happen. So this is one important finding. And there is something else known as the Hollenhorst plaque. I think most of the medicine students and cardiology we have heard of Hollenhorst plaque because these are cholesterol emboli and they can get deposited. So these are known as Hollenhorst plaques. And then infectoendocarditis, I have already discussed, you can get rot spot. Now, one of the important things is in all cases of Eisenmenger, look for fundus. Now, what do you get in Eisenmenger fundus is you can get engorged vessels, you can get blood hemorrhages, you can get microaneurysm, and finally you can get papilloedema. So these are the important things in a patient with Eisenmenger you have to see in fundus: engorged vessels, blood hemorrhages, microaneurysms, and papilloedema. So always look for fundus in all cases of Eisenmenger. Now, one of the two important diseases, autoarteritis. As you all know, autoarteritis is a cardiovascular disease, but first described by a ophthalmologist named Takayasu. So what he described was autoarteritis. The typical fundus finding is ischemic neuropathy. So you get something known as ischemia, retinal ischemia. So most common is retinal ischemia, and then you can get other findings like retinal vein congestion, capillary dropouts, microaneurysms, and AV stenting and all. So, but remember the hallmark is ischemic neuropathy. Now, last but not the least, coarctation of aorta. I think from your MBBS days, your ticking of the multiple choice question, you remember corkscrew retinal arterioles are seen in coarctation of aorta. So this is one of the important fundus examination is you have to see in coarctation of aorta. Why it is important? It helps you to differentiate from other causes of juvenile hypertension where you do not get this finding. You do not get corkscrew retinal arterioles. So this is one important thing. Yeah. Now, apart from this, I want to bring about some other important things like jaundice. Most common questions asked in MD examination: what are the cardiac causes of jaundice? 5 causes: congestive cardiac failure, cardiac cirrhosis, pulmonary infarction, patients with prosthetic valve because of hemolysis and all, and beta hemolytic streptococcal infection. These are the 5 important causes of jaundice in a patient with cardiovascular disease. You all should know. Take my words, these are the 5 causes of jaundice in a patient with cardiovascular disease. We all should know. Yeah. Now let's go to the congenital. These are one of the last markers, other markers of congenital heart disease. Now, I just before going into that, I'll just this is from the what we used to see. I think it's not very important at DM level to know, but what is low set of ears? We usually draw a line from the lateral canthus and out, and if less than 1/3 of the ear is above that line, or if more than 2/3 is below that line, it is known as a low set of ear. There are many diseases of chromosomal abnormalities associated with low set of ears. I'll come to few of them now. Now, what is a low hairline? Posterior hairline, if it is below the 5th cervical spine, it is known as low hairline. Just knowing a definition is enough. I think we should not go into much detail. Short neck, if the ratio of the height of C7 spinous process and the distance between the external occipital protrusion to the C7 is if a short neck is if the ratio when the ratio is more than 13.6. So just know the definition. And hypertelorism, I think this is one thing which is important. Some people tell us hypertelorism is increased interpupillary. So midpoint of the pupil, there is increased interpupillary distance. Now, how do you calculate it? Now, what do we do is inner canthal. So the canthi, the inner canthal and the outer inner canthal, the ratio between the inner intercanthal and the outer intercanthal, if it is more than 1.34, then it is known as hypertelorism. Why it is important? Because there are many diseases like Noonan's and all, Leopard syndrome, and many diseases which are associated with hypertelorism. I'll come into that. Or just remember, increase interpupillary distance or intercanthi distance more than 50% of interpupillary distance. So these are a full group which is associated with hypertelorism like Turner's, Noonan's, Leopard, Williams. I'll come to this now, just in the next few slides. Now, let's go one by one. In all patients when you're dealing with the patients with congenital heart disease, look from head to toe, all the markers, maybe 20, 25 diseases are there or more than that. I may not be able to cover, but some of the spotters are there, which I just wanted to discuss with you. I have got it with me. So this is one of the important Down syndrome. You all will know. I just don't want to discuss Down syndrome from our MBBS days. Down syndrome, MD days. Down syndrome is a short question, long question. So you know all the markers of Down syndrome, right from the facial features, other features head to toe. Let it be facial feature, mongoloid slant, simian crease, brachydactyly. I think one important point which I want to tell is from a DM point of view, Down syndrome has macroglossia or large tongue. What it causes? Tongue falls back. It causes then obstructive sleep apnea. That is one of the causes. Early PAH is very common in Down syndrome. There are many other causes. I want you to go and just go through the Perloff and find out. There are 3 to 4 causes of early pulmonary artery hypertension in a patient with Down syndrome. What are the other causes of pulmonary artery hypertension in a patient with Down syndrome? Very important, they may ask you in exam. So Down syndrome is associated with many other things. Now, this is one picture. I have encountered also one of the patient. One patient who comes with a common atrium, very large ASD or the common atrium. You see a short stunted female. There is a cubitus valgus. You see a lip tie. There is a deformity in the teeth. You see again cubitus valgus. And then there are many problems like a polydactyly and all. So this is something known as Ellis-Van-Creveld syndrome. I think just remember this sometime in somebody who is practicing cardiology, who takes cardiology, MD medicine, you may sometime in your lifetime see this case or a spotter. Ellis-Van-Creveld syndrome, short limbs, polydactyly, teeth abnormality, dysplastic nails will be there, polydactyly will be there, cubitus valgus will be there. They are usually associated with common atrium. Next, one more case is there, which we had seen some 6 months back. A patient presented with complete heart block, was ptosis, external ophthalmoplegia was there. Ptosis was there. And it turned out to be a Keohane-Sarre syndrome. You would have heard that these are mitochondrial diseases, Keohane-Sarre syndrome. So, ptosis, ophthalmoplegia. We looked for fundus, there was no retinitis pigmentosa. So that was a case of Keohane-Sarre syndrome. Now, next is CHARGE syndrome. Before coming to that, I'll come to that. So this is CHARGE syndrome. Now, what is CHARGE syndrome is, you should just remember what is CHARGE. Coloboma, heart abnormalities. What heart abnormalities you get is VSD and aortic arch abnormalities. But what you should look, other thing is, A stand for atresia of Coana. You can see in this child. Retarded or physical IQ. You can see the facial thing, genital abnormalities and ear abnormalities. So these are what is seen in CHARGE abnormality association. Most common CVS you get is aortic arch abnormalities. That is very common. The next is Turner syndrome. Now, in all patients who presents with congenitally at very young age, you see a coarctation of aorta at very less than 1 year, some family history and all. Always rule out Turner syndrome. Turners usually sometimes very familial and all associated with coarctation of aorta. They may have bicuspid aortic valve, some aortic stenosis, and then you see a coarctation of aorta. So rule out Turner syndrome in that. So what phenotypical markers you will see? I think you will be knowing it. Short stature, webbed neck, very short neck, low hairline, low set of ears, sealed chest. What sealed chest is? Wide means the nipples are widely spaced nipples. Deafness. So these are all the features of Turners which you have to look in the patient with if you encounter a very early or familial type of coarctation of aorta. Now next is one more important picture I wanted to show is this Holt-Oram syndrome. Now this is one more spotter. I think I have encountered 2 such cases of a Holt-Oram syndrome. This was both cases where with atrial septal defect. What you get is you get something known as hypoplastic or aplastic thumb. Hypoplasia of the thumb. You may not get a thumb or absent digits. Foreshortened hand. You see both the hands. This hand is foreshortened because there are. When you see the X-ray, there is abnormalities of the radius and ulna bone. Both the radius and ulna are short. So you get the foreshortened hand. And apart from that, there are many other deformities, but mainly radius ulna deformities and absent or small absent thumb you may get. So this most common cardiac defect is atrial septal defect, but you may get other thing known as the VSD. So this is known as Holt-Oram syndrome. Just remember this. This is one more important thing. Apart from this, you may get something known as Leopard syndrome. One again important thing where hypertelorism is an important finding. Pulmonary stenosis, hypertelorism. are associated with pulmonary stenosis. Next thing is Dye-George syndrome. Why this is important is patients, in all the patients, now I think it has become a routine recommendation, in all the patients with TOF, you have to do a genetic analysis and rule out a Dye-George syndrome. Or sometime when in the X-ray and all, you think that the thymus is absent thymus, or you do a blood level, see if hypocalcemia is there, do a genetic testing, you do a Q22Q11 mutation and all, rule out a Dye-George syndrome. What do you get? You get micronathia, again low set of ears, hypertelorism, and then this is what was that sternotomy scar was there. So hypertelorism, low set of ear, micronathia is a feature of Dye-George syndrome. Usually you get three important diseases: TOF, truncus arteriosus, and type B, interrupted aortic arch. So these three things are important. So in all patients with TOF, if you suspect there is some genetic abnormality, hypocalcemia, absent thymus, rule out Dye-George syndrome. So that is one important thing I want to convey through this slide. Now there are many other diseases, but one more important disease is Williams syndrome. Yeah, because there are you would be hearing Williams from your MBBS MD days. Williams is nothing but associated with supravalvular AS. Idiopathic hypercalcemia, it is associated with hypercalcemia. And what phases is it? You can see this phases: short stature, mental retardation, but most important thing is flat upturned nose. It is flat but upturned nose, associated again with hypertelorism, broad forehead. The forehead is very broad, baggy cheeks, and then there can be pegged teeth. It is known as actually pegged teeth. Malformed teeth known as pegged teeth. They are usually associated both with peripheral pulmonary stenosis and supravalvular aortic stenosis. So Elfine phases is something I think you may not encounter much, but sometimes we may encounter. So always remember this phenotype. Apart from this, rubella, we know all the in pregnancy. It is important to know this history because PDA is one thing which is associated the triad of deafness, cataract, and retinopathy. When these three things are there, congenital rubella should click us. So pulmonary stenosis and PDA should come into your mind. And then something known as Alagille syndrome. I think that is one thing, one of the rarest things. I won't go into the detail. Now, before wrapping up, 3-4 more important slide I want to tell. In all patients, if you see ascites, do not think that all the patient who has ascites has left heart disease because of pulmonary hypertension, they have right heart disease. All patients who have ascites, pedal edema, rule out. Most common is left heart disease causing right heart disease. Second is organic right heart disease, tricuspid valve disease. Third is constrictive pericarditis. Fourth is restrictive cardiomyopathy. Fifth is hepatic vein thrombosis. That is one thing which is always remember. These 5 differential diagnoses you should always remember in cases of ascites when a patient present with you in a cardiac OPD. Now, there are different physical findings. I won't go into detail, but some of them you will know. Like a patient with constrictive pericarditis, always look for a prominent X and Y descent. You may not get other things like C waves, V waves, which you get in left side heart failure, like a prominent V waves. However, in constrictive pericarditis, V waves are absent. It is only X descent and Y descent. However, one important, just I wanted to tell you, one important thing is ascites precox. Any patient with CCP, always remember the first place where ascites comes most of the time is the first with the ascites comes and then the pedal edema comes. Whereas in all other diseases, the pedal edema comes and then usually the ascites which sets in. So constrictive pericarditis is ascites precox. So the mechanism is not clear. They tell the hepatic constrictors which cause this and all. But there are all these causes of ascites. I think you should all know. Now, I won't go into detail, but clubbing is one important thing. There are only 2 important causes of cardiac causes of clubbing: congenital heart disease, and second is infective endocarditis. Infective endocarditis I have already discussed, and congenital heart. I think cyanosis is not one thing which I'm going to discuss. We will discuss in back to basics, either by me or somebody else will discuss. So this is not, cyanosis is itself a very big topic, but I just want to discuss some important theories of clubbing, as some examiner may ask you. The most important mechanism is a shunt theory. So what happens is this megakaryocytes, because of this congenital heart disease, they escape the happens. Why? Because of the right to left side. They escape the pulmonary circulation. They go to the systemic circulations, and then they go to all the peripheral circulation, like in your digits and all, and then they release PDGF and VEGF. So this is the platelet derived growth factor and all the fibroblast proliferation happens, and that causes clubbing. That is the most accepted theory at present. Apart from that, there are something known as the humoral theory, like the ferritin. Ferritin causes, estrogen causes, bradykinin causes. Then you have something known as neurogenic theory, and then hypoxia, genetic, and familial. So, but the most important is you should remember the PDGF, ferritin, and then hypoxia. These three things are important. Other causes of clubbing, I think I should not interfere in that now. Now, the two important things, any cases of thing, general examination, look for any scar. Let it be central scars, let it be left thoracotomy scars, let it be a right thoracostomy scar. So one of the important causes, left thoracotomy scars. Any patient, if they are 45 years present to you, congenital heart disease, or a 30-year congenital heart disease, or if whatever presents with you with the left thoracotomy scar, always you should remember what all surgeries can be done to a left thoracotomy scar. So the surgeries which can be done are closed mitral commissurotomy, PDA ligation, or coarctation of aorta surgeries are usually done to the left thoracotomy, PT shunt, pulmonary artery banding, and some CABGs nowadays, or a minimally invasive or a short incision they can do, and do through a left thoracotomy scars. Now, these 5 things you should remember, I think, through a left thoracotomy: CMC, PDA, coarctation, VT shunt, and PA banding. Now, what are the surgeries which are done through right thoracotomy? 3 important things are there at least: mitral valve repair, mitral valve replacement, both tricuspid valve repair, replacement, atrial septal defect closure, ASD closures, surgical closures, port and water shunt. I think those are usually not done now, but port shunts and water shunts. So these are usually done through the right thoracotomy scars. So these are the things which you have to remember, the scars. So right and left thoracotomy scars.